the National President, we have the presence of Dr. Shamsad Begum, that's our President, and we can see many of the seniors faculties from other states, including Dr. Ram Kumar, and welcome to you all. And I call upon Dr. Shamsad Begum, our President, State President, to have the official welcome speech. Thank you.
Thank you, Paul. Respected National President, Dr. Venkatagiri, our Secretary, Dr. Paul Raphael, all other senior ISA leaders, all other ISA members, today's Chief Speaker, Vinodhan Sir, and also the PG Corner presiding PGs like Dr. Nizreen and Dr. Aparna from the Government Medical College, Thrissur, our all senior leaders that I am seeing, and also especially Ram Kumar Sir from Manipal, and all other senior members, as well as the ISA members, my dear friends, colleagues, and the postgraduate students. Today we have the Chief Speaker as Vinodhan Sir. He doesn't require any introduction because he is the one of the important faculty members, invited faculty members of all the CMEs, as well as the national as well as the state conferences, and he is the HOD Department of Anesthesiology, Medical Trust Hospital, Kochi. And I also a warm welcome to you, sir, for accepting our invitation for presenting this academic session. And I also welcome our PGs like Dr. Nizreen and Dr. Aparna also for accepting the accepted to present the topics in a very short time, and I also welcome them. And also I welcome our meeting coordinators like Dr. Rajesh, Vijesh, and Binil. And a word, good evening to all once again. And now I invite our National President, Dr. Venkatagiri, to have the inaugural speech.
Good evening, President Dr. Shamsad. Today's speaker and chief guest, Dr. Vinodhan Sir. Then Secretary Paul, past Secretary Binil, coordinators Vijesh and Rajesh, Dr. Ram Kumar Sir, friends and colleagues. Continuing with this weekly PG teaching program, today we have Dr. Vinodhan taking class on pulmonary function test. Should have been, I think, 2 weeks or 3 weeks back because of his illness, could not take that time. We are happy that today morning, one of my pulmonologist colleague was telling that, Giri, do you have a class on lung evaluation? Because like we have always class on cardiac evaluation before surgery. Do you have in your CME? Yes, do you have? But I think, yes, evaluation, not only pulmonary function test, we should have that. I thought that, yes, that is also right. We should have evaluation of after this COVID and all. Definitely we should have that, because a lot of many patients, we see sudden death even post-operatively. And I have seen my own, even yesterday night, morning, we had a hernia surgery on a 100 kg man, spinal, nothing was there. Evening, night, 11 o'clock, post-op ward called me, sister, sir, patient is collapsed. I don't know why, because he had cough and he collapsed and died. We could not do any, the anesthetist was on duty, was there only. We do not know what is happening. Maybe due to post-COVID or anything. So we need more evaluation, even the COVID and pulmonary, not only pulmonary, lung evaluation after, before surgery, especially after COVID. This should be an initiative. Maybe that the next, maybe Vinodhan sir himself can make in a next sometime that total lung evaluation, not only pulmonary test. And this will be a initial class for that. Maybe Dr. Ramkumar also can add to that, because he's very senior faculty, and happy to see him today. He's with interest, he has come to this class. That means maybe that. Okay, all the best on this program. I think all will enjoy this class and the PG corner also. Okay, with this, let us move that. Next week, I want to again remind that we have Saturday, Sunday PG Quest and midterm CME. All should join from morning to evening and make it a successful program, because we have many faculties from all over India. And first day it is from Kerala and outside. Second day from all over India, we have the faculties. Join that also. Thank you.
Vijesh?
Yeah. Good evening, everyone. We move on to the academic sessions. And today, the first topic that is going to be discussed is pulmonary function test. And this is going to be done in two parts. Today, we'll have the first part. And we are lucky to have Dr. Vinodhan, who is the HOD of anesthesiology and critical care at Medical Trust Hospital, Cochin. And we are very lucky to have Vinodhan sir. He's one of the best teachers who will be there to help us out. And this is a good learning opportunity, which all the postgraduate students should make use of. So over to Vinodhan sir for his presentation on the first part of pulmonary function test.
I hope I am audible now.
Yes, sir.
Okay, right. Thank you for Dr. Samshad Begum, Paul Raphael, and Dr. Vijesh, Rajesh, and Vinil. All of them were instrumental in making me deliver this lecture. And thank you for waiting for almost about 4 weeks, because I was indisposed in the last time when you asked me to deliver this lecture. Thank you for the introduction. Can I
Yes, sir, you have to share
share the screen? Yes. Okay. I will. Is it okay?
No, sir.
No, sir.
No?
The PPT has not come, sir.
Yeah, it is in PPT now, actually.
Sir, we can see your entire folder, not the PPT.
Is it okay?
PPT has not come up, sir. Slide has not.
Sir.
Sir, onnoda share cheyidha madi, sir.
Yeah, this is the PPT on my screen. Is
Sir,
it
adonno minus cheyu, onno minimize cheyu. Adonno minimize cheyu. Adu kanitte share screen button nyekkitte PPT select cheyidha madi, onnoda. Kayinavana cheyidalla. Just onno minimize cheya, sir. Sir, slideshow exit cheyyanam, minimize cheyyanam. Adu കഴിഞ്ഞ് സൂമിന്റെ വിൻഡോയിൽ വന്നിട്ട് ഷെയർ സ്ക്രീൻ ബട്ടൺ ഞെക്കിയിട്ട് PPT സെലക്ട് ചെയ്യണം.
okay? Now?
ഇല്ല സർ, ഒന്നും വന്നിട്ടില്ല.
Okay. I think I have to restart the.
സർ ക്ലോസ് ചെയ്തിട്ട് ഓപ്പൺ ചെയ്താൽ മതി PowerPoint.
Yeah, I closed it. I'll have to open again. Is this seen now?
സാർ ഷെയർ ആവണില്ല ഒന്നും. സാർ ഷെയർ സ്ക്രീൻ ബട്ടൺ പ്രസ് ചെയ്യുമ്പം വിൻഡോ ഓപ്പൺ ആവുന്നില്ലേ? ആ വിൻഡോയിൽ പവർ പോയിന്റ് സെലക്ട് ചെയ്യുമ്പോൾ അത് തന്നെയാണ് വരേണ്ടത്. കഴിഞ്ഞ തവണ അങ്ങനെ ചെയ്തു സാർ.
I'm sorry, it's not working. Something is wrong. Shall I?
We can just log out and come back, I think.
That will be better, sir.
So you can just log out and just join back. I think it will work. I also had this issue in the last.
Okay. Is it coming now?
Yes, sir. Yes, sir.
Coming,
Okay.
sir.
Coming, sir.
You have to make it full screen.
Yeah, that time. Okay.
Yeah, yeah. Yes, sir.
Okay, we are back to the
Yes.
first slide. At least, is it okay?
Yes, sir. Okay.
Okay. So my topic, of course, is something that is very important as far as anesthesiologists are concerned, and something that long back only anesthesiologists used to do. Most of the major institutions, as I remember, actually had the anesthesiologists looking after the pulmonary functions. And even my institute, actually, I ran the function PFT lab for quite some time, till we had physicians and pulmonologists coming and taking over. So that must have been the state in almost all the institutions, because something that we normally require during our management of patients in the anesthesia and as well as in the critical care time is obviously a knowledge of the pulmonary function, and that has to be not only known, it should be actually used while you are giving anesthesia and while you are looking after the patient in the critical care period. These are non-invasive tests which show how well the lung is working, and they are actually very valuable investigations in the management of patients with suspected or previously diagnosed respiratory diseases, and they aid in diagnosis. Obviously, they help to monitor the response to the treatment and also can guide decisions regarding further treatment and intervention. They were initially designed for assessment of airway and parenchymal disease of the lung, and we always thought whenever you thought of pulmonary functions, we only thought about volumes and capacities. But now it covers many subspecialties, and it's a generic term now being used to indicate a battery of studies or manuals done to measure respiratory function related mainly to, but not restricted to, respiratory mechanics, parenchymal function, gas exchange, and cardiopulmonary interaction. There are many indications, and they can be broadly divided into medical, preoperative, and postoperative. The medical ones are to diagnose any respiratory disease. It definitely helps in diagnosing, or to an extent telling you what exactly is wrong with the lung. They are also used to screen those at risk, like smokers, patients who have occupational risk of contact to radiation, toxins, and drugs. You can also classify the type of disease into, let's say, obstructive, restrictive, or mixed disorder. And you can quantify the extent of the disease in percentages, in mL, in liters, and you can also monitor the progress of the disease, and that way you can set further goals to achieve and also document the response of the treatment. So it goes in many ways, it helps in managing the patients with respiratory disease. But for us who are managing anesthesia, it's important in predicting the perioperative risk in any patient who has got a history of lung disease. So it's important that you do this battery of tests, at least some of them, whatever is important for you, what is significant to that particular disease in the preoperative period, and predict the perioperative risk in the patient for that particular surgery, and in the postoperative period, what you can predict what can happen to these patients. In lung surgery, it actually predicts the resectability of the lung in thoracic surgery. You can measure the postoperative FEV1, DLCO, and of that we will be talking about later. In cardiac surgery, again, because lung is an important part of the cardiopulmonary interaction, it's important to know what is the lung function before you take up these patients for cardiac surgery. In patients with history of smoking, obesity, and patients who are in old age, patients who gives history of cough and dyspnea, they all need these tests to tell you what actually can go wrong in the postoperative in the perioperative period. In the postoperative period, it helps you to know how well we are done, how bad is the result in patients who underwent major lung resection, especially pneumonectomy. In lung transplant, it plays a part as a surveillance for the rejection, and also to predict the possibility of obliterative bronchiolitis that can happen in these patients after lung transplantation. It's also a method of assessment of disability, disability criteria when you give disability certificates. And in public health surveys, it helps you to know what is the incidence of lung disease in the population that you are actually surveying. There are hardly any absolute contraindication to these pulmonary functions tests, but there are some relative contraindications, like recent ophthalmic surgery of less than 1 week, neurosurgery of about 1 month, thoracic and abdominal cerebral aneurysms, because when you strain too much, they can produce problems in these patients. In patients with pneumothorax, you should not be doing this unless you really need to go in for a surgery. And in patients with unstable angina, recent myocardial infarction, recent thoracoabdominal surgery, again, it's better that you don't make them strain. And we have patients coming with COVID-19 and other active transmissible infections, and if you are going to do a pulmonary function, you should take all infection control measures. That is the only way to make sure that healthcare workers do not suffer from the actively transmissible infections. Patients who have active hemoptysis, patients with oral bleeding, patients with ulcers, secretions, they all form a real problem while you do these tests. So it's better that you control these before you go and do this test. So there are many tests available, and then they can be actually categorized into about 14 subgroups. I'm going to deal with only some of them in today's lecture. I will be dealing with bedside PFTs, dynamic and static volume tests, body plethysmography, bronchodilator challenge testing, and bronchoconstriction challenge tests, and the gas distribution tests. The other ones, like the Frohwall in loop, diffusion capacity of lungs, maximum inspiratory and expiratory lung pressures, and alveolar cardiopulmonary interaction, the impulse oscillometry and FeNO, and some of the tests, new tests for the children, and the COVID-19 modification challenges will form the second part of the lecture. It can also produce some problems, like some risks, because during the procedure, you can have dizziness during the test because you're making them take deep breath and breathe out fast, and you may be making them do it many times. That can give rise to dizziness. They may feel short of breath. It can bring on cough or asthmatic by a deep inhalation. You should also know that PFTs can be less accurate when you have a patient who is not cooperating well, who is on bronchodilators, and that can actually change improve the results, and you may not know the basal spirometry values. Patients on narcotic analgesics and can definitely have lower results, and patients who are pregnant, who have gastric distension, that it affects the ability to take deep breaths. Patients with extreme tiredness or asthenia again form a group which can give you very less accurate results. The bedside test are something that is usually simple, and then something that you can do when you're examining the patients, and it gives you an idea that this patient is somebody who can get into problem and who needs better diagnostic criteria before you take up these patients. One of the, although respiratory rate is not a test, but this is an essential part of your examination, and that is many times neglected. It's one of the most neglected criteria that is usually documented, and because of that, you may miss a patient who has got the rate of 35 and then think that his patient is fairly okay. You may not understand that the patient is tachypneic unless you really count and document. So this is my request to the postgraduates, that when you see a patient, one of the important things before anesthesia is to document the respiratory rate. That will tell you whether this patient is going to have some problem, and whether this patient needs further diagnostic criteria before you take up this patient. You all know about tests like Sabres's breath holding test, which tells you the cardiopulmonary reserve. If it is more than 25 seconds, you know the patient most probably has a normal cardiopulmonary reserve. If it is limited to 15 to 25 seconds, it is a limited cardiopulmonary response reserve. And if it is less than 15 seconds, you know it's a very poor cardiopulmonary reserve. There are certain ways of finding out the vital capacity from this, but these are very approximate values. You can really not rely on this. You also have the Schneider's mask blowing test, which measures the maximum breathing capacity, and you have to do it properly. That is the problem with this test, that many times it's not properly done, and it should be held at least about 6 inches in front of you and at the same level as your mouth, and then only you can actually get the correct test done, and that actually predicts you whether you have the adequate amount of maximum breathing capacity. You also have tests like Green and Barrett's cough test, which actually tells you the strength and the effectiveness of your cough, and that actually is equal to doing a PEFR or a FEV1, and it is an approximate method of measuring your ability to have a good cough in the postoperative period. Post-expiratory time again is a method by which you can find out what is the time taken to exhale maximally and forcefully by keeping a stethoscope over the trachea and listening. A normal FET of 3 to 5 seconds tells you that the expiration or the possibility of obstructive lung disease is less. If it is more than 6 seconds, you know there is a possibility of obstructive lung disease. If it is less than 3 seconds, there is a possibility of restrictive lung disease. There are also some appliances available, like the right peak flow meter, the mini rights, the deep bone of whistle, and the other small micro spirometers which are produced by Vitelograph and many other companies like the Mir Smart One, and this measures the peak flow and the FEV1, and that can give you a bedside value. They can be carried to the bedside, and actually you can get an approximate value of the FVC, FEV1, and PEFR. But what is usually done is you send these patients to a pulmonary function lab, and you find out the static and the dynamic lung volumes. And this is done by doing a spirometry, which assesses the integrated mechanical function of the lung, chest wall, respiratory muscles, and the airways. There are static tests and the dynamic tests. The static tests indicate the elastic and physiological properties of the lung and the chest wall. The dynamic tests will depend on the caliber and integrity of the airways. It actually tells you how fast you can push large amount of air through your airways. It was John Hutchinson who invented spirometer, and he said it measures the volume of air in an individual during exhalation as a function of time. Remember, these methods cannot measure the functional residual capacity, the residual volume, and the total lung capacity. It's important to remember that these values depend on demographics. The normal value will depend on the height, which is directly proportional to the volume of your lungs and the caliber of your airways. Remember that height is important, not weight. So it's the height which is important as far as the lung function is concerned. In case you don't know how to measure the height, probably in patients with hyposcoliosis, then the arms can be used to actually predict the volumes. Age is inversely proportional to the volumes the static volumes and the dynamic volumes. The male persons usually have a better lung volumes, and the ethnicity also matters as far as the lung volumes are concerned. So when you do a test, you will find that you can actually measure the tidal volume, and you can actually measure the inspiratory reserve volume, the expiratory reserve volume, thereby finding out the vital capacity, which forms all these three together forms the vital capacity. And you can you can compute the inspiratory capacity, the expiratory capacity, and you have to do a different tests to actually find the total lung capacity and the functional residual capacity and the residual volume. These are things that you actually learned in your undergraduate days. You know that tidal volume, it's in inspiratory reserve volume, expiratory reserve volume, and the residual volume, and also the total lung capacity, vital capacity, and the inspiratory capacity. I'm not going too much into it mainly because of want of time. One thing I wanted to stress upon is the functional residual capacity, which you can't measure with this dynamic and the static lung test. This is something that is really important to the anesthetists and the critical care personnel. it is a sum of residual volume and the expiratory reserve volume, or the volume of air in the lungs at the end expiratory tidal position. This is about 30 to 35 ml per kg, usually about 2,500 ml in an adult male, but it decreases in the supine position, decreases in obese patients, decreases on induction of anesthesia, and decreases very much further you put the patient in a head low position. Remember, this is important as an oxygen store because this is represents the volume of air in the lungs at the time of expiration. And that is what is there almost throughout the respiratory cycle. And it is the buffer for maintaining a steady arterial PO2. The inflation of this or improvement in this helps in preventing atelectasis and also improving the oxygenation. And it also minimizes the work of breathing. It can be measured, these volumes, the functional residual capacity, as well as the total lung capacity and the residual volume can be measured only by body plethysmography, single breath and multiple breath nitrogen washout, or HRCT in full inspiration, helium dilution method, and radioxenon scintigraph. It's important to also compute the RV-TLC percentage because if it is more than 140%, it increases the risk of barotrauma, pneumothorax, infection, and reduced venous return due to high thoracic pressures. If it is more than 180%, this is an indication for lung volume reduction surgery. How do you measure it? One method is the whole body plethysmography, which is actually based on the principle of Boyle-Marriott law, which tells you that P into V, that is pressure into volume, is a constant. So P1 into V1 is equal to P2 into V2. And that is the principle used in computation of the volume of gas in the thorax. The formula is given below, and it quantifies the total thoracic gas volume and the non-communicating gas volumes. What you do is that you use this equipment to measure the compressible gas volume within the thorax, and this is a more accurate method than other methods. The patient sits in an airtight box, and patient tries to inhale against a closed mouthpiece from the FRC. That is how you measure the FRC. The procedure, before you take this patient into the tight compartment, airtight compartment, you make sure that patient is seated comfortably, and procedure explained in detail, and include saying that the door will be closed and the nose clip will be applied, and you will have to do things as we tell you. The plethysmograph door is then closed, and time is allowed for the thermal transient to stabilize and patient to relax. So it's important that the thermal transient stabilizes, because the law, if you remember, the P into V is a constant only when the temperature is a constant. So make sure that temperature stabilizes before you start this procedure. Then the patient is instructed to attach the nose clip and a mouth peep, and breathe quietly until a stable end expiratory level is achieved. That is achieved when you actually do about 4 to 5 breaths. 4 to 5 tidal breaths are done, then you achieve that level. And when you reach that level, you've seen that there is a electronically controlled shutter in the mouthpiece, and that mouthpiece, the shutter is now shut electronically at the time of at FRC or near FRC. It is shut for 2 to 3 seconds, and then the patient is asked to take gentle panting breath. This gentle pants should be at a rate of about 60 breaths per minute. That's about 1 hertz of breath. That is 1 per 1 second. And after about 2 to 3 seconds, the shutter is open, and then he is asked to take normal tidal breath, two or three tidal breaths, followed by a full expiration, followed by a deep inspiration and a slow expiration, slow and full expiration. So what you're doing is a expiratory full expiration, giving you the going up to residual volume, giving you the expiratory reserve volume. Then you take a deep breath and followed by a slow full expiration, giving you a slow vital capacity breath. So we will get a complete vital capacity and a residual volume. I mean, minusing that ERV from the from this, you can actually compute it. ERV is here, FRC is there. So if you you can find out if you know the FRC, then minus ERV, you will get the residual volume. And then if you add that residual volume to the vital capacity, you will get the total lung volume. That is the way you get FRC, residual volume, as well as the total lung capacity. The other method is the helium dilution technique, where patient breathes in and out from a reservoir with known volume of gas containing trace of helium. Helium gets diluted. During this, the helium gets diluted and it dilutes the gas previously present in the lungs. So if you have 50 ml of helium introduced and helium concentration is 1%, then the volume of lung is 5 liters. This is the way you calculate with a helium dilution test. You can also do the nitrogen method, which measures where patient nitrogen washout method, where patient breathes 100% oxygen and all the nitrogen in the lung is washed out. The exhaled volume and nitrogen concentration in that volume is then measured, and the difference in the nitrogen volume at the initial concentration and the final exhaled concentration allows the calculation of the intrathoracic gas volume and the FRC. Then you come to the dynamic lung volumes, which is measured by a forced spirometry. So this forced spirometry will assess the ability of the lung to move large volume of air quickly through the airways to identify the caliber as well as the integrity of the airway. Most often what we perform in the lab, in the pulmonary lab, is this forced volume measurement. And that will give you the forced vital capacity, forced expiratory FEV1, forced expiratory volume in 1 second, forced expiratory volume in 1 second divided by the forced vital capacity, several forced expiratory flow rates, and the forced inspiratory rates, also the maximum voluntary ventilation, as well as the maximum breathing capacity. The forced vital capacity is the maximum volume of the air that can be breathed out as possibly, as rapidly, and as completely as possible following a maximum inspiration. It's characterized by full inspiration to total lung capacity, followed by an abrupt onset of expiration to residual volume. That is what you do here. You take a deep breath and then breathe out as fast as possible, as explosive breathing as possible, and breathe into the residual volume. That is how you do a forced vital capacity measure, forced vital capacity maneuver. So in that, you also measure in the first seconds, how much is the volume that is expired. That gives you the forced expiratory volume in 1 second. So you get the FVC as well as FEV1. Then from that, you can compute the FEV1 by FVC. There are certain things you should be careful when you do this. Certain criteria should be satisfied. There should be a good start of the test without any hesitation, and it should be an explosive start. And the peak should be reached within 0.12 seconds. So this, when you take this, when you do this, this part should be done within about 0.12 seconds. There should not be any coughing. There should be any glottic closure in the first second. There should not be variable flow. There should be, say, a smooth flow. And the expiratory plateau should be only after 6 seconds. The plateau is where we call it a plateau when the flow rate is 25 ml per second for at least 1 second at the end of the expiration. And there should not be any early termination. That should be, the termination should be more than 10 seconds. There should not be no early. That can be made out when you also measure the forced inspired vital capacity, and you should find out forced inspired vital capacity should not be more than FVC by about 100 ml. Okay, so if the difference between FVC and FIVC is more than 100 ml, that means there is an air leak, and then that cannot be taken as a correct value. And it should be reproducible. So you actually do at least 3 to 5 tests. Say through 5 times you do this, and of this, you take the 2 largest values, and these 2 largest values for FVC and FEV1 should vary by no more than 150 ml in adults and not more than 100 ml in children. That is when you call it as reproducible spirogram. The acceptable spirogram is like this. You see, no hesitancy. It rises up very well without very smoothly, and you reach the expiratory plateau after 6 seconds, and it terminates at about 10 seconds. Whereas this is not an acceptable one. You have hesitancy. It comes a little later, and it's not smooth, and it's an early termination. Similarly, this is again an acceptable spirogram, but this one is not. You have a cough before 1 second is over. This is the reproducibility. If you look at these 3 spirograms, you will see that there is a difference of nearly about more than 300 ml between these spirograms. And similarly, here also, it's not, there is difference of more than 300 ml between them. And whereas this is acceptable, there's hardly any difference between them. It's only about 30 to 40 ml between them. And again, these are very acceptable maneuvers. So in this test, what you do is you make them do the tidal volume breath, then you ask them to take a deep breath and breathe out as fast as possible, as long as possible, and you get the forced vital capacity and also the forced expiratory volume in 1 second. So from this, you can find out what is the normal for that particular patient according to the nomogram that you have, and then compute according to that nomogram and see whether it is 80 to 120% of the normal. If it is 80 to 120%, it is normal, and 70 to 79% shows you that it's a mild reduction in the FVC and the FEV1. 50 to 69% is a moderate reduction. 35 to 50% is a moderately severe reduction, and less than 35% is a severe reduction of the predicted. You can also do a slow vital capacity maneuver where a maximum amount of air is exhaled in a relaxed expiration from a full inspiration to residual volume, and exhalation is terminated after 15 seconds. This is useful when you find that FVC is reduced and you also know that there is an airway obstruction. So you want to know whether is it really a reduction in the FVC, or is there a reason why it is reduced because of airway obstruction. So slow exhalation will result in a lesser degree of airway narrowing, and the patient may produce a larger or even normal vital capacity when you do that. So after you do a forced vital capacity, if you find it is reduced, you can do a slow vital capacity. And if that gives you a normal vital capacity, or slightly almost a larger vital capacity, you know that it is the FVC was reduced because of the airway obstructive in the patient. So if in the restricted disease, both the slow as well as fast maneuvers should show a reduction in the vital capacity. You use before the spirometry, if these patients may come with bronchodilators, but if you want to have a baseline spirometry, you have to stop them. And depending on the beta agonist, the agent that is used, you should stop them for adequate amount of time. If it is a short-acting inhaled beta agonist, it's like albuterol, also known as salbutamol. It's 4 to 6 hours. If it's Expiratory, it is 12 hours. A long-acting one, salbutamol, you have to stop for 24 hours. Ultra-short long-acting ones for 36 hours. It's also important that you confirm the reversibility if you are suspecting asthma or COPD. So you use salbutamol metered dose inhalant, so about 100 microgram is administered by metered dose inhaler and the spacer, and repeat the spirometry after about 10 to 15 minutes. And if you find that there is improvement in FEV1 or FVC by 12% or 200 ml, or FEF by 25 to 75 increases by 20%, then you know there is an acute bronchodilator responsiveness for the patient. That means the patient is an asthmatic, or the patient has got COPD with significant bronchoconstriction. You also do a bronchoprovocation test when you find that spirometry is normal, but the patient gives history of allergic induced or exercise induced asthma. But it's in contraindication when the FEV1 is less than 60% or less than 1.5 liters, and stop this bronchodilators. When you do this test, stop the bronchodilators. As I told you earlier, according to the half-lives, you should stop the bronchodilators, and then you give them methacholine, which is a non-selective muscarinic agonist. It should be aerolized and administered sequentially, starting with the concentration of 0.016 milligram per ml to 16 milligram per ml until FEV1 decreases by about 20%. You know that it can produce cardiac arrest. It can also produce acute asthma, so you should be careful. Another important thing is to remember that it can be like a mini restriction can be mimicked, and it can be a pseudo restriction when you have a patient who has got bronchoconstriction. So what happens is when you have a bronchoconstriction, when you have let's say when you have a patient with mixed disorder, the FEV1 will be low, FVC will be low, and the FEV1 by FVC also will be low. But you don't know, when you look at the FVC, you will find, so you will actually think that this patient has got a mixed disorder. But you should make sure that this patient has really got mixed disorder only by after you do a total lung opacity or do a slow vital capacity maneuver. Because when you have a bronchoconstriction, there is air which is trapped. This air trapping will happen in patients like this, where you find even on X-ray there is air trapping, and when you have air trapping, the residual volume increases, and that will eat into the forced vital capacity. So thereby you will find that forced vital capacities decrease, and you will think that this patient has got a mixed disorder. So it's important to do total lung capacity and make sure that all do a slow vital capacity to make sure that you're not dealing with a pseudo restriction. So you can have obstructive pattern and restrictive pattern when you You can see that looking at the forced vital capacity. Forced vital capacity is decreased or normal in an obstructive pattern, and forced expiratory volume in 1 second is decreased in an obstructive pattern, and FEV1 by FVC ratio is decreased, whereas total lung capacity is sometimes most often normal or increased. In a restrictive pattern, FVC is decreased, FEV1 is decreased or normal, but FEV1 FVC is normal and total lung capacity is decreased. So how do you come to this? It's very simple method is to use this way of looking at this these values. You look at these values by starting with finding out whether there is an obstruction. Okay, so see, there are 3 steps to this. One is to find out whether there is obstruction. So you look at the FEV1 by FVC, you find there is an obstruction. Yes, if there is an obstruction, quantitate that obstruction. If you can also see the response to bronchodilatry and confirm there is an obstruction. After that, the step 2 is to look at the FVC. And looking at the FVC, we can see whether there is a restriction. And you know that, as I told you earlier, it can be a pseudo restriction. So to find out whether there is pseudo restriction, you have to actually do a total remember to find out the total lung capacity, or do a slow vital capacity measure and see whether there is a improvement in vital capacity in the when you do the slow vital capacity. So slow vital capacity goes more than that, you know that there is no restriction. So you have to do only 3 things, look at only 3 things. One is the FEV1 by FVC, which will tell you whether there is a restriction, whether there is an obstruction, and then confirm that obstruction. Go ahead and look at the FVC, and that will tell you whether there is a restriction. If the restriction is there, you also make sure that there is definitely a restriction. And to do that, you have to look at the TLC or the slow vital capacity. Okay, so if you see that, you can do that in a patient like this. Here, there is no FEV by FVC is normal, so there is no obstruction. So there is a possibility of a restriction or a normal pattern. So then you find that, look at the FVC, then you find that FVC is not lower than the limit of normal. That means there is no restriction. So it is definitely a restrictive lung disease. To make sure that this has got definite restriction, then you should do the total lung capacity. And if the total lung capacity is also normal or normal or higher, then you know that this is you're not dealing with any disease. You have a normal spirometry. Let's look at this. This is a patient where there is again FEV1 by FVC is normal, and then you know it could be a restrictive or normal disease. Then you look at the FVC, and that is again lower than the normal. The FVC is FEV1 by AC is normal, but FVC is 56%. So if it is 56%, you know that is it lower than the normal. So it's a restrictive pattern. So you should find out whether total lung capacity is not. If it is not, is it lower? So total lung capacity here is only 59%. Okay, that tells you that there is a restrictive pattern. So looking at these 3 values, you know whether there is a restrictive or obstructive disease, or whether it is a mixed disorder. You look at this one, the FEV1 by FVC is abnormal, it is low, so it is an obstructive pattern. You can quantitate this by using the FEV1 as a percentage of the predictor value. Okay, you know that FEV1 by FVC is low, it is only 33%. So it is a severe obstructive disease, and then you find out whether the FVC is normal. FVC is again is less than the lower limit, so FVC is 58%. It's only 58%, so it is less than the normal limit. So there's a possibility that there is also a restricted disease. Okay, then you have to make sure that you have to see whether there is whether total lung capacity is done, and whether that is low. When you look at the total lung capacity here, that is normal, or probably even higher than normal. So that means actually it's a pure obstruction, and there is no mixed obstruction. There is no restriction in this patient. Is what you saw as a restriction in the FVC is a pseudo restriction produced by bronchospasm producing air trapping of the lung. Look at this. There is FE1 by FVC is low, so it's an obstructive pattern. And if you can also quantitate this, you look at this, it is 54%. It's a moderate to severe obstruction. And then you look at the FVC. FVC is again 58%. Okay, so 58%. And then you look at the total lung capacity. Look at that, and this total lung capacity also is less. That means you are dealing with a mixed disorder where there is obstruction as well as restriction. This is the way you look at these values and then compute and find out what kind of disorder it is, whether it is restrictive disorder or whether it is obstructive disorder, or that is whether it is pure restriction, pure obstruction, whether it is a mixed disorder. This is just to remind you that the restriction could be because problems in the lung, problems in pleural cavity, problems in the chest wall, or problems because of neuromuscular disorder. When you do the testing, you also look at the maximum flow rate during the FVC, okay? That is called as the peak expiratory flow rate. And this should occur within the first 0.1 second. That is when you know that they have done a proper explosive maneuver. That is when you produce the maximal peak expiratory flow rate, because this peak expiratory flow rate also depends on the muscle power. Okay, so it is also tells you how effective this patient's cough is going to be. So you have to do it after a maximum inspiration. Patient expires as possibly and as quickly as he can, and then you look at the peak expiratory flow rate. It's a crude estimate of the larger airway function. It is effort dependent, but is highly reproductive. And it's also measured by a peak flow meter, which you can carry with you, or the patient can carry with you, and then tell you how bad is his larger airway function. You can also test other parts of this spirogram, and then you can get the FEF ratio of 25%, the 75%, and also the 25 to 75%. This 25 to 75%, which is earlier also known as maximum mid expiratory flow rate, MMVFR, is the important part, because this is not depending on your muscle power. You cannot increase it by blowing hard. So this depends on the caliber and integrity of your airway, especially the small airway, not the large airway. So that actually tells you the small airway function. That's why this is an important factor to look at when you look at the spirogram. So when you look at it, it is measured in liters per second. It will reflect the effort independent expiration and the status of the small airway. It is highly variable and it depends heavily on the FVC. If the FVC is very high, you can actually have a slightly higher percentage of FEF. But important thing is, when you find it's lower, you should think of a small airway dysfunction in this patient. and anything below 60%, you should it make you think of a small airway function. And sometimes this is the first function that fails in a patient who is a smoker. The other one is the maximum breathing capacity, the MBC, which measures the speed and efficiency of filling and emptying of the lungs during the increased respiratory effort. It denotes the neuromuscular strength and the maximum volume air that can be breathed in and out of lungs in 1 minute by the maximum voluntary effort. It's something that cannot be done by all patients. It's quite difficult for them to do it. So usually what is done is you look at the FEV1, multiply by 35, you get the almost an approximate maximum breathing capacity, and that can be used as a measure to measure the maximum breathing capacity. Otherwise, you ask the patient to breathe as quickly and as deeply as possible for 12 to 15 seconds and measure the volume and extrapolate it to 1 minute. But the only thing is that even 15 seconds of hyperventilation can lead to respiratory alkalosis, fainting, and then we can also tire them out. Patients with emphysema, patients with airway obstruction, patients with respiratory poor muscle strength can all have MBC which is lower than normal. This we have gone through already. This is something that you should remember when you look at these parameters. That is a FVC should be thought when you look at the parameter, you should assess it and see whether this patient can go through the surgery without any problem. And FVC, which is less than 70%, is a problem both in upper abdominal and thoracic surgery. FEV1 less than 70% predicted is problematic in upper abdominal surgery, and in pneumonectomy less than 2 liters, lobectomy in pneumonectomy less than 2 liters is a very bad choice, but you can afford to take them up for lobectomy even when it is less than 2 liters. But there also, if it is less than 1 liter, it is difficult to, it is possible that you can get into perioperative and postoperative complications. But a small bed resection or a circumflexectomy can be done with adequate precautions and good anesthesia management, even in a patient with a very severe restriction and very low FEV1 and FEVC of less than 0.6 liters. FEV1 by FVC less than 65%, you will definitely get into problem because there's a patient who's got an obstructive disease, and both in thoracic as well as upper abdominal surgery, you should be careful in these patients. If you look at the FEV of 25 to 75, anything less than 50% predicted, it gives you problems during upper abdominal surgery, and in pneumonectomy less than and the lobectomy, again a lower FEF by 25 to 75% gives you a higher chance of difficulties during the perioperative period. But remember, PFTs help only to support or exclude a diagnosis, and a combination of a thorough physical and history and physical examination as well as supporting laboratory data and imaging is helpful in developing an anesthetic plan for patient with pulmonary dysfunction. So you should not think of only PFT when you look at the patient. You look at all other evidence which is available, go through a good history and physical examination, then only you take up this patient and you look at the risk assessment of this patient. In the next, I'll be dealing with many other parameters, the flow volume loop, DLCO, and cardiopulmonary interaction will be the major ones that I'll be dealing with. Thank you very much. Before I conclude, I want to invite you all to the SARC conference, which is going to be held. It is the 14th International Congress of Anesthesiologists in the SARC countries. It's being held in Cochin. It's being hosted by ISA National and is being organized by ISA Kerala and ISA Cochin. And remember the dates, 12th, 13th, and 14th of August 2022. Welcome to Le Meridian Convention Center. All of you should attend this. Thank you.
Thank you, Vinodhan sir, for simplifying pulmonary function tests. You have made it quite simple for us to understand. And thank you for stressing on the need of looking at total lung capacity before we label patients as obstructive or restrictive lung disease. The talk is open for any queries that the people have. You can unmute and ask sir directly. Sir, we have noticed that in these results, they always mention that these normal values are from like 80 to 120%. They are always giving it above 100. Why is it like that, sir?
Yeah, the reason is that it is because of the fact that there is always a medium value, and then you have values on both sides of the spectrum of the normal. So if you look at what you look at should be looking at should be the 5th percentile of the median value of the value that you get a normal of the value should be 5th% of the normal value predicted for that particular patient. So that in simple terms is like 80 to 120%. It's actually for people with good knowledge of statistics, it is 5th percentile.
Sir, I am Dr. G.K. Murthy. I wish to ask, good evening, sir.
Good evening.
I wish to ask, actually, there is one test called differential bronchospirometry, which I have seen it regularly being performed in PGI. But most of the discussions, the differential bronchospirometry is not included in most of the lung function test lectures. Then is there any reason why that is not done now, or whether it is not much value, or whether it is difficult because it is difficult, it is not being done, or what is it there is no role for differential bronchospirometry?
You're talking about differential spirometry for both the lungs, isn't it?
Yes, sir.
Using the WM tube.
Differential bronchospirometry with the Carlin's tube.
Yeah, so you use a WM tube and then, okay. I know this is a thing which is usually not done, mainly because it involves putting a WM tube and then having the patient to undergo tests. This is something that I was associated with when I was in Jipmer. There was a physiology experiment going on of doing bronchospulmometry. One of the physiology lectures was doing a thesis work, and I was in the thoracic department at that time, and I was interested because I have the anesthesia experience. So I used to put this patient. The patients used to be. These patients used to be pre-medicated with anti-sialagogue, and then under topical anesthesia, you put the WM tube, take them to the pulmonology lab, and then do a bronchospirometry. Now, it is a tough thing for the patient. Whatever said and done, I used to pity those patients, really, because you are carting them through to the lab, and then you cannot afford to give them adequate sedation because the values will be different. So it used to be something that is experimental, but and quite a bit of problem for the patient. I don't think it can be done in that particular way. The only way that we can do is when you're doing a thoracic surgery and you're putting a WM tube already, it is possible for us to do that that particular time. If you connect your, if you have a ventilator which can give you the values that you want, it is possible for you to analyze You can analyze the flow volume loops and then that will give you the differential spirometry of each lung, and that is possible. That is the only differential spirometry being done on a patient who is under or being ventilated either during anesthesia or in the post-operative period. You can do a differential spirometry. I can touch upon this in the next lecture, but then remember that this is something that is not done in a conscious patient anymore. I don't think people, it's possible that if I had done that, if I do that now in my institute, I think most of my patients will sue me.
Actually, I had seen it in my pulmonary lab in PGI. The technicians doing it, we're under local anesthesia. They keep the WMN tube in the lying down position and they make the patient in sitting and they do the test under perfect local anesthesia. I have seen them with sprays and all, but they have not. I have not seen much problem, but this is not regular. It is definitely it is at risk. I know that, but I have seen it.
Yeah, I've done it. But then what I'm saying is that it's not something that I would like to do, because definitely the patient used to have a problem. And you are doing in a patient, either patient is normal or patient is diseased. And then you're going to actually complicate the disease. So it's okay for doing an experimental work, but I don't think a patient may, if you explain what is going to be done to a patient, you will not get a proper consent from them. That I'm very sure. The patients I did this probably did not even understand what I'm going to do.
If the patient once becomes unconscious, there is no question of doing lung function test. At least this dynamic function test we cannot do. So
you can definitely do a flow volume loops can be made. That is the only thing you can do.
Test cannot be done.
No, definitely not.
That also can be done when the patient is conscious. I have seen it being done, but regularly it's not. I have seen number of lectures in the pulmonary functions nowadays. This test is excluded.
I think world over people don't do it probably. That may be the reason. It will be probably done in labs on canine lungs and pig lungs. That may be the only ones which is being done.
Thank you, sir.
Any questions in chat box? No questions in chat box.
Thank you. I was either very clear or everything went over that.
No, sir, it was very nice. Where the basics were, the foundation has been laid for probably the next session.
Okay. I think Ramkumar is here. He may add something.
Yes, Vinodhan. Yeah.
Yes.
I think your lecture was very clear. You actually covered a lot of ground for the time that you spent, less than an hour. And I think you've done a very excellent job. So there's just one thing I wanted to mention was, when you do the match blowing test, which is one of the things that is still done by the bedside sometimes, and there are a lot of examiners which will ask this. We just have to, the PG must be aware that this is not done with pursed lips. It's not like blowing a birthday candle, where you purse your lips and you're able to create a much larger flow. So you should have your mouth, the patient should be instructed to keep the mouth wide open and then blow at, as you said, 3 inches, 6 inches, and 12 inches. So if you purse the lips, you'll get a false result. So you're able to generate higher expiratory flow rates through a pursed lip. So that is one thing that we need to remember. Otherwise, I think there's nothing that I wanted to add. Thanks, Vinodhan.
Yeah,
also,
I did.
SJK Murthy, same Gopal Krishna Murthy, whom I worked along with in JIPMA.
Thank you, sir.
Yes.
Nice to see you.
Yes, Gopal Krishna Murthy. We'd like to see you if you can, bring on your video. But I made you out from your voice. So I think to add on to what Vinodhan said, the differential lung test, as you were talking about, the split lung function, used to be done in the earlier days, and it's very, very uncomfortable for the patient. placing a double lumen tube in a conscious state and then checking individual lung function. And I think now with more modern techniques of predicting, especially for lung resection, we have the three-legged stool, various tests that are done. I think this is kind of archaic. You probably won't do this anymore. One, for the discomfort of the patient, and two, there are better tests that give you more, predictability regarding residual lung function following lung resections. So,
more safer tests, I think.
Yeah.
More safer tests.
More safer and more comfortable. I think, patients, nowadays, patients used to say, you do whatever you want. You're like God. But I think that is not anymore the case. You really have to, if you're going to put your patient to so much discomfort, there must be a justification. And I think that is one of the main reasons why this has been dropped.
And another reason actually is that, we have the HRCT now, which
Correct.
can actually give you many of those volumes and problems that you wanted to predict with a differential lung disease, because that differential lung is actually shown in the HRCT better than what you can get from those values. The values told you in effect only the difference between two sides.
Right.
In the side where exactly is the problem, that you can see, even that can be seen in an HRCT. So I think that has made the difference when you have an HRCT. And then actually HRCT now comes in some of the, I think Siemens has got a thing called Symbostat or something like that. That has got algorithm which will actually tell you the residual volume, total lung capacity, as well as the functional residual capacity. It is possible. Not many of them, it's a very costly software, so it's not available for everywhere, but they have actually come out with it. Only thing, the problem is that patient has to take a full breath. It should be in full inspiration and hold it for some time, which may be a problem sometimes, but if they can do that, then it gives you the values. And that actually is better than doing even plethysmography. So that may be the reason why in Western world nobody does it, because from that they can get all these values. The Sebres, all those tests, actually I didn't go into details about the bedside tests. I mean, there are so many tests available, and then it's there in most of the books. So, but I think, as you said, postgraduates should know how to do it, how it should be done. Yeah, that's important.
Just one more thing, Vinodhan. I think when you cover your part 2, I think just want to tell the postgraduates, please read the chapter by Peter Slinger, Anesthesia for Thoracic Surgery, from Miller's textbook of anesthesia. I think then you'll understand Vinodhan's second part of his lecture much better, because he's laid the foundation, as we said, but I think he's going to probably build on this foundation, and reading that chapter by Peter Slinger will be definitely useful.
Thank you, sir. If there are no more queries, I think we'll move on to the PG corner. I wish to thank Vinodhan sir once again for that wonderful lecture, and we hope to see you for the part 2 after 2 weeks. Thank you, sir.
Right. Thank you. Thank you.
Thanks, Vinodhan. Thank you.
Thank you.
Lovely
Bye.
listening to you. Yeah.
Thank you, sir, for the advice also, Ramkumar sir, and also thank you, Vinodhan sir, for the excellent lecture. It was so simple, and we, I think most of them have followed it very well. Thank you, sir.
Thank you.
So, ma'am, can we move on to the PG corner?
Yeah, okay.
So we move on to the next session, that is the postgraduate corner. We have where we discuss drug and equipment. And this time we have students from the Government Medical College, Thrissur, who have accepted our invitation, and a short notice they have agreed to present 2 topics. So I wish to welcome Dr. Nisreen Nasruddin and Dr. Aparna M. So over to Dr. Aparna M for the first, to Dr. Nisreen Nasruddin for the first talk on Atracurium and Cis-Atracurium. Dr. Nisreen, your Yeah, you can go to slideshow and start the topic.
Nasrin, you are still not audible.
Nasrin, go to slideshow.
Yeah, okay, from the beginning, you can start. Okay. From beginning. Yeah.
Do you have any problem with your mic? Dr. Aparna, you both are not audible. Dr. Nasrin, if you have any problem with your mic, you can just write in the chat box. The slides are visible. Yeah, you have to unmute. Yeah, you are now. You are unmuted.
Am I audible?
Just try to speak once more.
Aparna, എന്താ പറ്റിയേ? Start.
But our
Just to
mic
go
and
to
the
the
mic and the issue.
slide ഷോയിലേക്ക് പോയിട്ട് തുടങ്ങിയാൽ മതി. അൺമ്യൂട്ട് ചെയ്യോ?
Unmuted ആണ് മാഡം. അപർണ എം unmuted ആണ്. അവരുടെ മൈക്ക് എന്തോ ഇഷ്യൂ ഉണ്ടോ എന്ന് എനിക്ക് സംശയമുണ്ട്. കാരണം മൂവ് ചെയ്യുന്നില്ല മൈക്ക്. അത് ഞാൻ സംസാരിക്കുമ്പോൾ നമുക്കൊന്നും കേൾക്കാൻ പറ്റുന്നില്ല.
മാഡം അവരുടെ ഫോണിൽ വിളിച്ച് സംസാരിക്കുക.
ഞങ്ങൾ പറയുന്നത് കേൾക്കുന്നുണ്ടോ?
You call with their phone. She is not able. ഇത് കേൾക്കുന്നില്ല അല്ലേ? You call her over her mobile and ask what it is because you know her mobile. Madam student alle. You can call her over mobile and ask what is.
അതല്ലെങ്കിൽ വേറൊരു ഇൻസ്ട്രുമെന്റ് കയറിയാലും മതി. You can join from other computer or mobile.
Join from another device.
First മറ്റവർ വേണമെങ്കിൽ ഇവർക്ക് സമയം കൊടുക്കാം. Let the other person present.
Both join from same computers. Dr. Aparna, if you got some other computer or mobile, you can join from that and you can try from there, if possible.
Sir, am I audible now?
Yeah, you are audible. You are audible. So you can use the same computer for slideshow, and audio will become for other computer. So you have to mute one. You mute one instrument.
Or the mobile on.
Aparna, again, you are not audible.
Good evening, everyone.
Yeah.
Today I'll be talking about the drug Atracurium and Cis-Atracurium. We know the muscle relaxants, they are broadly classified based on the mechanism of action into depolarizing and non-depolarizing muscle relaxants. And based on the chemical structure, it is divided into steroidal compounds and benzyl isoquinoline compounds, which is further classified based on the duration of action to long-acting, intermediate-acting, and short-acting drugs. So Atracurium, it's a non-depolarizing muscle relaxant belonging to the benzyl isoquinoline group, having intermittent duration of action. It was synthesized in 1981 by Stenlake and his colleagues. It is a bis-benzyl tetrahydroisoquinoline compound. The isoquinoline nitrogen is connected by a diester containing hydrocarbon chain. It's composed of 10 isomers separated into 3 geometric groups designated as cis-cis, cis-trans, and trans-trans in the ratio of 10:6:1. In this diagram, this is the isoquinoline nitrogen part, and in the center part is the diester containing the hydrocarbon chain. It is available as Atracurium bisylate. It is a sterile, non-pyrogenic aqueous solution, available in ampules of 2.5 ml containing 25 milligram. So the concentration is 10 milligram per ml. The common route of administration is intravenous. The intramuscular route of administration is said to cause excessive tissue irritation. Mechanism of action. Atracurium, it's a competitive agonist at the alpha subunit of the postsynaptic nicotinic receptor at the neuromuscular junction. It competes with acetylcholine for the binding sites, thereby preventing the depolarization of motor end plate and the subsequent skeletal muscle contraction. Unlike the depolarizing muscle relaxants, Atracurium, it doesn't induce any conformational change in its receptor. This is a diagram of acetylcholine receptor. Here it's a pentameric complex containing 5 subunits, 2 alpha subunits, 1 beta, 1 delta, and 1 epsilon subunit. Now, the acetylcholine, it usually binds to the 2 alpha subunits of this receptor. But the non-depolarizing muscle relaxant, it binds to one of the subunits and will prevent the acetylcholine from binding to its receptor, thereby preventing the subsequent reactions. Atracurium is 82% protein bound. It does not cross the placenta or the blood-brain barrier. Metabolism is mainly by 2 pathways. One is the Hoffman elimination. It constitutes about 1/3 of the metabolism. Now, Hoffman elimination, it is a non-enzymatic chemical degradation at the physiological pH and temperature. Here, the quaternary ammonium group is converted to the tertiary amine by cleaving the carbon-nitrogen bond. As I said, it's a pH and temperature dependent reaction. Hence, a high pH and temperature favors elimination. So in patients in acidosis and hypothermia, the duration of action of the drug will be prolonged. The second pathway is the non-specific ester hydrolysis, which constitutes 2/3 of its metabolism. And because the metabolism is not affected by the renal or the hepatic dysfunction, Atracurium is the preferred drug in critically ill patients. The metabolites are laudanocin, which is a tertiary amine. Then the other products are monoquaternary acrylate, alcohols, and acids. Laudanocin is a CNS stimulant and it crosses the blood-brain barrier. It is said to decrease the seizure potential, though the evidence in humans has not been recorded. It has no neuromuscular blocking activity. And elimination is 70% via bile and 30% via urine. The common uses of Atracurium are tracheal intubation, surgical relaxation, and to facilitate the mechanical ventilation for the patients in ICUs. Dose for intubation, 0.5 milligram per kilogram. ED95. ED95 means the dose required to suppress 95% decrease in the force of contraction or the amplitude of electromyogram of the adductor pollicis muscle following an ulnar nerve stimulation. So the ED95 dose of Atracurium is 0.2 to 0.25 milligram per kilogram. And the dose of intubation, it is usually twice the ED95 dose. Onset of action is 3 to 5 minutes. Duration of action is for 30 to 45 minutes. Maintenance dose can either be given as an intermittent injection at a dose of 0.1 milligram per kilogram or as continuous infusion at a dose of 5 to 10 microgram per kilogram per minute. The common side effects of Atracurium is histamine release. Because of histamine release, there can be skin flushing, erythema, decreased systemic vascular resistance causing hypertension, and also tachycardia. The clinical effects of histamine release, they are usually seen only when the plasma concentration rises to 200 to 300% above the baseline value. Effect of histamine release is usually short duration for about 1 to 5 minutes, and it's dose related. It has got a positive inotropic and chronotropic effect on the myocardial H2 receptors. Secondly, it has got respiratory effects. That is, it increases the airway resistance, and there is high chance for bronchospasm, especially in patients having hyperreactive airway. Now, third, allergic reactions, though it's a very rare condition. Next, about Cis-Atracurium. Cis-Atracurium is again a non-depolarizing muscle relaxant of intermittent duration of action. It is cis isomer of Atracurium, that is 1-cis1-R. It constitutes about 15% of the marketed Atracurium by weight and more than 50% in terms of potency. Cis-Atracurium is 4 to 5 times more potent than Atracurium. Available as Cis-Atracurium becylate in vials of 10 ml containing 20 milligram. That is a concentration 2 milligram per ml. Metabolism is mainly via Hoffman's elimination for about 77%. About 23% is via organ-dependent elimination. In that, 16% is via kidneys. The laudanum produced is about 5 times less when compared to Atracurium, as Cis-Atracurium is more potent. Clinical uses are again for tracheal intubation, for muscle relaxation, as well as for mechanical ventilation in ICUs. Dose for intubation, 0.15 to 0.2 milligram per kilogram. Onset of action takes about 4 to 7 minutes, which is slightly longer when compared to that of Atracurium. Duration of action is for 35 to 50 minutes. Maintenance dose can either be given as intermittent injection at a dose of 0.02 milligram per kilogram or as continuous infusion at a dose of 1 to 2 microgram per kilogram per minute. Side effects are very less for Cis-Atracurium as it is devoid of histamine release. So the cardiovascular effects are not seen, and anaphylactic reactions are very rarely reported. This is a table comparing the Atracurium and Cis-Atracurium, which I have already told. So to summarize, both Atracurium and Cis-Atracurium, they are non-depolarizing muscle relaxants of intermittent duration of action. Cis-Atracurium is more potent than Atracurium, but it's costly. Metabolism of both, they are organ independent, mainly via Hoffman elimination and ester hydrolysis. And because of this, it is safe to use in patients with renal and liver dysfunction. The drug metabolite laudanum produced is very less in Cis-Atracurium. So it is the most preferred muscle relaxant in critically ill patients and for prolonged ventilation. Thank you.
Thank you, Dr. Nasrin. Over to Shamshad, ma'am. And you have to unmute. You have muted.
Okay. Nasrin, you have presented it very nicely and briefly. And okay, it was very good. And the only thing that we have to highlight is when we compare both the Atracurium as well as Cis-Atracurium, Cis-Atracurium is mainly by the Hoffman elimination. And there is only a minimal percentage which is excreted through the kidney also. And the ester hydrolysis is it present? Ester hydrolysis for Cis-Atracurium?
No ester hydrolysis for Cis-Atracurium.
For Cis-Atracurium. Okay. That is the main point that we have to understand. So Cis-Atracurium is better safe than Atracurium when we use it. And also the incidences of the anaphylaxis is also much less. That is the incidence of bronchospasm. Okay.
Okay.
So any other questions, Vijesh?
Regarding the cold chain for transporting Cis-Atracurium, I think you can mention that, Nisreen. Because Cis-Atracurium should be kept refrigerated, and if you
refrigerated at 2 to 8 degrees Celsius. So since it's a temperature and pH dependent, there is chance that the potency will decrease.
Yeah, correct. The potency will decrease. If it should be protected from light.
Light and temperature.
Yeah, it should be kept at 2 to 8 degrees centigrade, especially when you transport the drug. That you can mention. That's a difference. You can mention it as a difference, because the potency will be lost at 5% per month if you keep it at 25 degrees room temperature. Okay. Yeah, that cold chain you can mention in the Cis-Atracurium.
Okay.
You have presented really well, and you have covered most of the things. It was nice. Anything, Binil, anything you want to add? Or
we don't have any questions in the chat box. I think we can move on to next topic, that is Nasopharyngeal and Oropharyngeal Airway by Dr. Aparna from Government Medical College, Thrissur itself.
Yeah, so over to Aparna.
They can change the PowerPoint and they can start.
Good evening, everyone. Hello, am I audible, sir?
Yes, yes, you're audible. You have to put your slideshow first.
Yes, I have put it.
No. It's still Atracurium.
It's not seen.
It's not seen.
It's not seen, Aparna.
You unshare this first. Stop sharing of this.
Okay, sir. So is it visible now?
Yes, it's visible.
So good evening, everyone. Today, my topic for presentation is airway. I'll be talking on both oropharyngeal airway and nasopharyngeal airway. So what is an airway? Airway is a device which helps to maintain the patency of the air passage for unobstructed breathing. It's mainly of two types, oropharyngeal airway and nasopharyngeal airway. First, we will discuss the oropharyngeal airway. This is an image of Gödel's oropharyngeal airway. So, as you all know, under anesthesia and sedation, the muscles in the floor of the mouth and pharynx supporting the tongues relax, and the tongue and the epiglottis fall back into the posterior pharynx, obstructing the airway. The airway, the artificial airway helps to maintain the patency of the airway tract by preventing the falling back of the tongue and the epiglottis. The first airway invented was Gödel's airway by Arthur Ernest Gödel with the aim of maintaining a patent airway. Oropharyngeal airway is a curved apparatus made up of metal, plastic, or hard rubber. It has a flange at the proximal end, which limits the depth of insertion. It may also serve as a means to fix the airway in place. The flange may or may not rest on the patient's lip, depending on the particular size of the airway selected. Then it has a straight block portion, which fits between the teeth or the gum, and it has a pharyngeal end which rests between the posterior wall of the pharynx and the base of the tongue. This exerts pressure along the base of the tongue and also pulls the epiglottis slightly forward. When inserted, the distal end should lie just above the epiglottis so as not to irritate the laryngeal inlet. The uses: it prevents the obstruction of the upper airway passage, prevents biting and occlusion of the orotracheal tube, protects the tongue during biting and seizure activity, facilitates oropharyngeal suctioning, provides a better mass fit for ventilation, helps in the insertion of tubular devices into pharynx or the esophagus. The insertion technique. Appropriate sites is selected by measuring the distance between the patient's incisor and the angle of the jaw. If a smaller size airway is selected, it can cause kinking of the tongue and it may obstruct the gas movements. If the larger air size is used, it can cause obstruction by displacing the epiglottis and can also traumatize the larynx. The pharyngeal and laryngeal reflexes should be depressed so as to avoid coughing and laryngospasm. So the technique is the patient's mouth is opened, the airway is inserted with its concave side facing upper lip. When the junction of the bite portion with the curved section is near the incisors, airway is rotated through 180 degree and it is inserted further until it lies in the oropharynx. So correct placement ensures airway patency and by seating of the flattened reinforced section between the patient's teeth or alveolar margin if the patient is edentulous. Alternatively, a tongue blade may be used to depress the tongue and the airway is inserted with a concave side towards the tongue. As it is advanced, it is rotated to slide round behind the tongue. Coming to types of oral airway, first we'll discuss about Gudel's airway. It's the most frequently used airway. It is a hollow oropharyngeal airway with a phalange and a reinforced bite portion. These bite portions are color coded and is available in sizes from 0, 000, 00, and 0 to 6. It is made up of polyvinyl chloride. It has a gentle curve that follows the counter of the tongue and has a tubular channel for air exchange and suction. Then this is an image of Waters airway. It is named after Ralph Waters and is available in sizes 0, 0, 0 and 1 to 7. It is a metallic oropharyngeal airway with 2 holes at the pharyngeal end. It is hollow and has a nipple on the flange for oxygen and suction. It can be cleaned with soap and water. This is Safa's airway. Safa's airway. It is a S-shaped airway that look like 2 airways are joined together. It is available in sizes for both adult and pediatric. It's made up of non-traumatic soft rubber. It plays a role in resuscitation. This is Cornell's airway. It is a metallic hollow oropharyngeal airway and can be cleaned with soap and water. Repeated sterilization may cause softening and its design could have use in management of patients' airway during sedation. This is Berman's intubating pharyngeal airway. It is tubular along its entire length and is open on one side and it can be split and removed from around a tracheal tube. It has no enclosed air channels. The sides allow passage of suction catheters and provides air channels. The center may have openings to permit suction. It has a flange at the buccal end and is designed for use during fiber optic intubation. It can also be used as an airway or to aid blind orotracheal intubation. Then this is an image of Ovasapien fiber optic intubating airway. It is designed to deliver fiber scope close to the larynx. It has a flat lingual surface that widens at the distal end. The buccal end has 2 vertical side walls. Between the side walls is a pair of guide walls. They curve towards each other, leaving a space for tracheal tube up to size 9. They are flexible so that the airway can be removed from around the tracheal tube after intubation is done. This is Patil-Syracuse oral airway. It's also known as Patil endoscopic airway. It's made up of aluminum. It's mainly useful for fiber optic intubation. It has lateral suction channels and a groove in the center of the lingual surface for the fiber optic scope. A slit in the distal end allows manipulation in the anterior-posterior direction. This is Williams airway intubator. It is designed for blind orotracheal intubations. It's used to aid fiber optic intubation and is also used as an oral airway made of plastic. It is available in 2 sizes, number 9 and number 10, which can admit up to size 8 and 8.5 endotracheal tubes respectively. The proximal half is cylindrical and the distal half is open on its lingual surface. The complications are airway obstruction if the tip of the airway presses the tongue or epiglottis against the posterior pharyngeal wall. It can be a contributing factor for tissue edema, especially in surgeries of prolonged duration and in sitting position. It can cause ulceration of tongue if it's used for a prolonged period, damage to teeth, lingual nerve palsies rarely. The second topic for today is nasopharyngeal airway. This is an image of nasopharyngeal airway. It's also known as nasal airway or nasal trumpet. It is an alternative device that can be used to maintain the airway by inserting it through the nose. It's made up of soft plastic, polyurethane, or latex rubber. It has a fixed or an adjustable flange and at its proximal end and a beveled distal end. It curves to fit the curvature of the nasopharynx. It is better tolerated than an oral airway in patients with intact airway reflexes. The size is designated by the inside diameter in millimeters. The uses, it's especially useful in patients with limited mouth opening, or in patients having trauma or pathology of the oral cavity, or in patients with loose tooth, or those are in poor conditions, and during and after a pharyngeal surgery in infants with Perry-Robin syndrome, to apply continuous positive airway pressure to facilitate suctioning as a guide for fibers. It's also act as a guide for nasogastric tube and is used to dilate the nasal passages in preparation for nasotracheal intubation and to maintain ventilation during oral fiber optic endoscopy. Contraindications include anticoagulation, a basilar skull fracture, any deformity of the nose or nasopharynx, history of nosebleeds requiring medical treatment. Insertion technique, the length of airway to be inserted is measured by the distance from the tragus of the ear to the tip of the nose plus 1 inch, or it's measured as a distance from the tip of the nose to the meatus of the ear. The diameter of the nasal airway inserted is same as needed to insert a tracheal tube. That is 0.5 to 1 mm less than the orotracheal tube size. Each side of the nose should be inspected for size and patency in presence of polyp before insertion of a nasopharyngeal airway. A vasoconstrictor may be applied before insertion to reduce the trauma. After lubricating it along its entire length, it is held in the hand on the same side as it is to be inserted. It is inserted through the nostril in a posterior direction, perpendicular to the plane of the face, with bevel against the septum. If there is resistance, slightly rotate the tube to facilitate insertion at the angle of nasal passage and nasopharynx. If there is still resistance, you can attempt passage through the other nostril, or a smaller size airway should be used. If placed appropriately, the pharyngeal end has to lie above the epiglottis and below the base of the tongue, with flange just outside the nostrils. So types of nasal airway. This is an image of Bardak's airway. It's made up of rubber and it has a large flange at the nasal end with bevel at the pharyngeal end. This is a binasal airway. It consists of 2 nasal airways joined together by adapter for attachment to the breathing system. The distal tips are near the larynx, just below the tip of the epiglottis. It is used to provide anesthesia or provide CPAP to the babies. Then we have cuffed nasopharyngeal airway. It is similar to a short cuff tracheal tube. It's inserted through the nose into the pharynx. After inflating the cuff, it is pulled back until the resistance is felt. This is an image of Linter nasopharyngeal airway. It's a clear plastic airway with a large flange. The distal end is flat and is not beveled. It is supplied with an introducer which has a balloon that can be inflated and deflated through a one-way valve attached to the introducer. This is a Rouge airway. It's made up of red rubber. It has an adjustable flange at the nasal end. The pharyngeal end has a short bevel. Complications are airway obstruction. Especially if a larger size airway used, it may act as a foreign body in the airway. Epistaxis due to trauma to the septal mucosa, nasal polyps, or adenoidal tissues. Then trauma to the nose. Then longer airways can cause laryngospasm, latex allergy if especially the nasal airways contains latex, then tissue edema, ulceration and necrosis, CNS trauma in patients with basilar skull fracture, retention, aspiration or swallowing. Thank you.
Aparna?
Yes, madam.
Hello.
Yes, madam.
So when we compare with the oropharyngeal airway as well as the nasopharyngeal airway, what is the main differences in between these two?
The main difference is that it is better tolerated. The nasopharyngeal airways are better tolerated in a semi-conscious patient or in a conscious patient.
Yes. But the oropharyngeal airway we cannot
We cannot-
introduce in a semi-conscious or
conscious induced.
conscious patient, especially in the recovery period, because they will try to push it out when we keep the oropharyngeal airway in a semi-conscious or a not fully sedated patient. Only in unconscious patients we can use the oropharyngeal airway. But so that is the significance of nasopharyngeal airway. We can keep it safely in a patient with the semi-conscious or when they are fully conscious also. Till we require, we can give oxygenation as well as we can provide the maintained airway, especially in a semi-conscious patients. This is the main differences. Otherwise, it was a past presentation and you have completed almost the different varieties of airways also. Vijesh, any other comments? Okay.
It was a well presented topic, and she has covered almost everything. There are any queries, any other comments from Binil? Anything else you want to add?
How to select the proper size of the airway?
Okay. So if it's an oropharyngeal airway, we have to measure from the patient's length of vertical distance from the incisors to angle of the mandible is selected. And if it's an nasopharyngeal airway, distance from the tip of the nose to the tragus plus 1 inch is added for nasopharyngeal. Or otherwise, we can measure the distance from the tip of the nose to the external auditory meatus.
Okay, good. What are the complications that you can expect while you are using nasopharyngeal airway?
Nasopharyngeal airway can cause mainly, if a longer airway is used, it can cause airway obstruction, and also it causes epistaxis because of trauma to the septal mucosas, or if there is any nasal polyps, etc., adenoidal tissues, etc. Then for prolonged, if it kept for a prolonged period, it can cause ulcerations. Then if used in a patient with a basilar skull fracture, it can cause trauma. Then aspirations.
Yeah, that epistaxis is a nightmare for anesthesiologists, especially if you don't notice while the patient is under monitored anesthesia care and when we give sedations to a patient. Vijay sir, we don't have any questions in the chat box.
Yeah, we don't have.
And also it should be very well lubricated, otherwise it can traumatize when we introduce the nasopharyngeal airway. It should be very well lubricated. Okay. And also it should be the correct size for the patient. And also make sure that, especially in a trauma patient, you have to make sure that there is no trauma to the mandible as well as to the maxilla or the nasal tract or intracranial trauma, because more chance for, suppose if there is any trauma, there is more chance for infection to the brain also can occur. So we have to be very careful when we select the nasopharyngeal airway in a semi-conscious patient. Okay.
Okay, ma'am.
Vijesh, anything more?
Nothing else now.
So
I think we will thank Aparna and Nasreen for the wonderful presentations.
Vijay sir, we can allow our seniors to unmute and they can add their comments or ask the questions if they want.
Yeah, sure.
I am Dr. G.K. Murthy. I wish to ask nasotracheal tubes, original nasotracheal tubes, the bevel is facing towards the septum. That was the original description of nasotracheal tubes. Nasotracheal tubes, the bevel should face the septum. The right and as well as the nasotracheal tubes used to be different. I have seen left as well as right nasotracheal tubes in my examination tray, but not have not used. But in the airways, is there a difference whether the bevel is facing the septum? Is there any type like that, or both are same?
So we usually insert with the bevel facing the septum, sir. Bevel against the septum only, sir.
But actually angulation will be there, no? Bevel is always towards the left only in the most of the nasopharyngeal airways.
Okay, sir.
Okay, sir. Most of the cases, we will check the patency of the nasal tract before we introduce the nasopharyngeal airway. So as far as possible, we will try to use the side to which the nasopharyngeal airways, the bevel is facing.
Okay, madam.
Sir,
Thank you, madam. Thank you.
sir, any other thing that we have to be careful when we introduce it? Sir, anything more?
Actually, it will, if the bevel is towards the lateral side, it will take a portion of the biopsy of the turbinates, sometimes adenoids and all can go. That is the problem. That's why the bevel should face the septum. That's what is the description of nasotracheal tubes. But
Yes,
I am
okay.
asking, is there a model of airways also, left as well as right nostrils? I have not seen, but
So far not, we haven't seen, sir. Almost the same. Aparna, you have shown that pictures, isn't it? The different sizes of the nasopharyngeal airway.
most of the it are facing the left only.
Yes.
Yeah.
And Rouge one is a bit rough, and the Saclad and rest of the models, they are a bit softer, more soft. Rouge is a bit rough, and it may be, sometimes it may injure. It's just like Rouge endotracheal tube only.
Yeah.
But the Saclad and the rest of that Bordeaux, all this, they are soft.
Yes.
Nasopharyngeal airways, I have seen. So that is my
Yes, sir.
knowledge about nasopharyngeal tubes. Okay, madam. Thank you. Thank you.
Okay, sir. Thank you, sir. You are,
Madam, there is a question from Dr. Lalit Kumar. He can ask directly in the chat box. Dr. Lalit, please unmute and ask. That will be better.
That is not a question. Just to add on to PG students, if patient is intubated by nasal tube and demand postoperative nasal airway, the tube can be pulled out just above the uvula, and that can be remain as an nasopharyngeal airway. So no need to just extubate and put
yes, okay.
another nasal airway.
Okay.
Thank you, sir.
Thank you.
That's a good way we can do it here.
Sir, so at the time we have to reduce the length of the
Yes, madam.
endotracheal tube, isn't it? So to reduce the dead space.
Yeah, 2 centimeter has to be remain and rest has to be
Yes,
cut.
and the
Yeah.
rest we have to be removed.
That I
Okay.
mentioned in the text.
Yes. Okay, sir.
Thank you, ma'am.
Okay. Thank you, sir.
Both were HODs. Lalit Kumar Raigar is obstetric anesthesia expert, and he was, I think, secretary of obstetric anesthesia, regular visitor to our CMEs. He is from Rajasthan. SGK Murthy is HOD in KIMS Amalapuram, where Dr. Kameshwar Rao was working. Kameshwar Rao now just retired from there and sitting at home. No, he is not seen in this thing. Both are very senior persons are HOD and regular visitors for our all workshop from other states.
Okay, thank you all the seniors for giving us the advices, and also to Ramkumar sir. Okay. Thank you, sir.
Thank you, ma'am. And just a reminder again, our ISUMMITCon will be a complete virtual conference. ISUMMITCon 2022 will be a virtual conference, and it will be held on 26th and 27th March. So it will be next Saturday and Sunday from morning to evening. So request all the PG students and our faculties and senior members to join us on ISUMMITCon 2022 on next 26th and 27th. So next Saturday and Sunday. Madam, over to Madam.
Yeah. But Arif is there. Vijish,
Ma'am.
shall we?
Yeah,
shall we
wind up. Yeah, we'll wind up the session.
wind up? So Arif is there. Otherwise, Pinal, you can.
Yeah, please. So since Dr. Paul is not there, I would like to conclude the section by the last program of today's session, that is a vote of thanks. So I thank Vinodhan sir for giving us the wonderful lecture on the PFT, and we are expecting the second part of the PFT during our next month or after 2 weeks. So thank you, sir, for the excellent lecture. I extend my sincere thanks to our PG students, Dr. Aparna and Dr. Nisrin, not Nasari. Okay. Dr. Nisrin from Government Medical College, Trichur. So it was a wonderful talk presentation by Dr. Nisrin about Cis-Atracurium and Atracurium. And Aparna, you have presented well Oropharyngeal and Nasopharyngeal airways. So thanks to our young colleagues. I extend my sincere thanks to all the senior leaders, including our National President, Dr. Venkatagiri, for joining us today evening. And extend my sincere thanks to our coordinator, Dr. Vijish and Dr. Rajesh, for coordinating today's session. And extend my sincere thanks and congratulations to Madam for organizing today's program. Shamshat Madam, our President, for organizing today's program, along with Secretary Dr. Paul Raphael. Thank you all.
So we'll break for dinner.
Yeah.
Dinner. Where is the dinner?
Dinner next week we are expecting from Isamit God.
Yeah, in Shillong. You come to Shillong. We will host a good dinner there.